Good morning, everyone. I'd like to welcome you to this webinar for the JPAL Healthcare Delivery Innovation Competition, and thank you all for taking the time to be with us today. My name is Quentin Palfrey, and I'm the Executive Director of JPAL North America at MIT. I'm joined today by Professor Emmy Finkelstein, Ford Professor of Economics at MIT, and the Scientific Director of JPAL North America. Today, we're very excited to tell you about our Healthcare Delivery Innovation Competition, which will support government agencies at the federal, state, and local level and other healthcare partners in tackling policy challenges using rigorous evaluations. We hope that some of you will consider applying to the program by submitting a short letter of interest before June 17th. I'm delighted to have Professor Emmy Finkelstein here with me today, who chairs JPAL North America's Healthcare Delivery Initiative. Professor Finkelstein will talk about some of the evaluations that have already been conducted or are underway in connection with this initiative. Finally, you'll have a chance to get answers to your questions about our initiative. Here's a quick look at the agenda for today's webinar. We'll be taking questions through our Twitter account at the handle @JPAL_NA and through the chat box on the right-hand side of your screen. If you have a question, feel free to send us a tweet or to pose a question through the chat box at any time, and we'll respond to as many questions as we can after the presentation. We're also available to talk in more depth at any time over the next few months. There'll be contact information on the last slide, but you can feel free to reach out to me at qpalfrey@mit.edu or to our initiative manager, Jason Bauman, at jbauman@mit.edu. Now, first, I'd like to give you a brief introduction to JPAL. JPAL was founded in 2003 as a research center based in the Department of Economics at MIT. JPAL stands for the Abdul Latif Jameel Poverty Action Lab, and our mission is to reduce poverty by ensuring that policy is informed by scientific evidence. JPAL's specific focus is on using rigorous evaluations to answer policy questions. Each dot on this map represents a randomized evaluation led by one or more of JPAL's affiliated researchers. To date, JPAL affiliates have led more than 700 ongoing and completed projects in 67 countries. Of these, more than 150 are healthcare projects. In 2013, we launched the JPAL North America office here at MIT. We leveraged the scholarship from 131 affiliated professors from over 40 universities, as well as a full-time MIT-based staff of more than 15 researchers, policy experts, and administrative staff to generate and disseminate clear scientific evidence on which anti-poverty social policies work and why. With our Healthcare Delivery Innovation Initiative, we build on our affiliates' experience partnering with governments and other partners across the U.S. Professor Emmy Finkelstein, who is with us today, is one of these researchers. Later, she'll be discussing her scholarship in healthcare delivery, as well as some of the other work that JPAL North America's affiliates have conducted in connection with the Healthcare Delivery Initiative. As an organization, JPAL works to improve the effectiveness of social policy through three core activities. The first activity consists of the evaluations led by our affiliated researchers who are supported by JPAL's professional staff. The second is policy outreach, which generally takes place either on the front end by connecting researchers and policymakers who can design and launch new evaluations, or on the back end by sharing the results of these evaluations with policymakers and other stakeholders. The third activity is capacity building, in which JPAL staff helps policymakers to become more informed consumers of evidence and equips them to partner with researchers for evaluations. Turning now to the Healthcare Delivery Initiative, the challenge emerges from the fact that the healthcare system touches on the lives of every American at every phase of our lives, from our birth to our death. We spend about $3 trillion a year on healthcare, and that's about 17% of our gross domestic product. As the Affordable Care Act, or Obamacare, turns 6 years old, and as technology continues to revolutionize the delivery of healthcare, dramatic changes in the healthcare system are unfolding at the federal, state, and local levels. Despite the best efforts of policymakers, disparities in healthcare access, quality, and outcomes persist along racial and socioeconomic lines. No one has more at stake in the success of health reform than the poorest members of our society. An emerging field of research applies rigorous methodologies such as randomized controlled trials to examine what works in healthcare delivery and why. But there's a lot we don't know about which healthcare delivery strategies are most effective and efficient. At JPAL North America, we're committed to advancing this promising research by identifying programs that can improve patients' quality of life and enhance the sustainability of the healthcare system. This research can help health leaders to learn what has been tried and proven elsewhere, and which of their own policies and programs are the most effective, and on what measures. A couple of years ago, JPAL North America launched its Healthcare Delivery Initiative. This work is generously supported by the Laura and John Arnold Foundation and by the Robert Wood Johnson Foundation. The goal of the Healthcare Delivery Initiative is to build partnerships between leading scholars, policymakers, and practitioners to generate rigorous evidence of strategies to improve the quality and value of healthcare delivery in the United States. To date, JPAL North America has supported 14 rigorous evaluations of innovative programs. In a few minutes, Professor Finkelstein will talk about some of this exciting research. In the course of our work, both in the healthcare space and in other areas relating to poverty and social policy, JPAL North America has identified some challenges that we're seeking to address through this new competition. Many times, policymakers are thinking about implementing important and valuable innovations and have a desire to conduct rigorous evaluations of what's working and why, so they can direct their resources to where they will have the greatest impact. But there are often constraints on conducting this research. It can be hard to free up the staff time to think through research design. Often there are challenges relating to data systems. Sometimes the organization's staff don't have experience with rigorous evaluations or know what it entails. And it can be challenging to find an experienced academic partner who can conduct the research. So this competition, the Healthcare Delivery Innovation Competition, is meant to help healthcare leaders with these challenges, to lay the groundwork for a partnership with a scholar to run a rigorous evaluation of an important healthcare delivery innovation that will have a positive impact on the lives of the poor. So in connection with this competition, JPAL North America will give selected partners essentially three things. The first thing is that we'll devote some time of our research and policy staff to help you think through how to design an evaluation and give you some of the benefit of our experience of having done these in the past. Secondly, we'll award recipients $50,000 in flexible funding that you can spend however you want. But this, we hope, will allow your staff to focus on research design, allow you to work out any data challenges, and allow you to focus on working with us to build a feasible research program. Third, we'll also provide some strategic consulting from experienced researchers in JPAL's affiliate network to help work out some of the more technical and harder issues relating to research design. And the hope is that through this engagement, some of the recipients will go on to partner with our with affiliates in our network to design a research proposal that you can then apply for additional funding along with that JPAL affiliate. Typically, these larger grants range from $150,000 to $400,000, and the process for that would be for a joint application between a JPAL affiliate and one of the recipients of our competition awards. So what are we looking for? We're looking for programs that can serve as models for deploying health and social services to improve health outcomes and enhance the accessibility and affordability of quality health care. We're looking for an institutional commitment to rigorous evaluation. And there are some requirements for adequate scale, scope, and data infrastructure to make this kind of a design feasible. We're also looking for people who are interested in partnering with a JPAL affiliate on a policy-relevant study on the back end of this process. And we're always particularly interested in projects that align with our mission to reduce poverty by ensuring that policy is informed by scientific evidence. So one of the pieces of a successful application is that there has to be a feasible opportunity for a randomized evaluation. And there are 3 steps to follow when implementing a randomized evaluation. The first is to identify your population of interest, or in other words, all of the individuals who would be eligible to receive your program. The second is to select randomly members of your population into either your control group or the treatment group. And then the third step is to deliver the program you would like to evaluate to the treatment group, while the control group receives the status quo. By comparing the average outcomes of interest for these 2 groups, we get an accurate estimate of the impact of our program. The value of randomization is that the construction of this process allows for the treatment and the control group to have the same characteristics on average. And then the differences after the program implementation can be attributed to the impact of the program itself. A randomized evaluation is not the only tool for generating evidence, and it doesn't fit every circumstance, but it fits a lot of circumstances, particularly where resource constraints prevent you from offering the innovative program to everyone you think could benefit from it. And in the circumstances where it does fit, it can provide very valuable evidence that can inform decision-making, resource allocation, and policymaking. So before I turn it over to Professor Finkelstein, I just want to explain how you apply. So this is a very easy application process by design. We're just looking for 3 to 5 page letter of interest by June 17th. And we're also happy to help think through the process and help think through what might work in the letter. So feel free at any time to email us and set up a time to chat. You can reach me personally at qpalfrey@mit.edu. You can reach the initiative manager, Jason Bauman, at jbauman@mit.edu. My phone is 617-715-5128. And you can also reach us through Twitter at jpal_NA and through Facebook, where we're JPAL North America. Now it's my pleasure to introduce Professor Amy Finkelstein. She's the co-scientific director of JPAL North America. She's the Ford Professor of Economics at MIT, and she's the chair of the Healthcare Delivery Initiative.
Thank you, Quentin. And this is Amy Finkelstein. I'm delighted so many of you have joined us today and are interested in participating in our Healthcare Delivery Initiative. What I wanted to do is just tell you very briefly about how I got involved in randomized controlled trials on healthcare, why I therefore started JPAL North America and our Healthcare Delivery Initiative, give you some examples of some of the projects we have currently underway, mostly just to whet your appetite and give you a sense of the wide range of things that one can study with a randomized controlled trial, and encourage you to get your creative juices flowing to think about things that might work for you. So to begin where I began, as of course everyone knows, there has been for a long time an active debate in the policy world over Medicaid. Opinions, as you can see from these sample headlines, range from the view that expanding Medicaid would actually be a wonderful thing, not only for poor people and their lives, but actually for states, and save them money by getting people out of the emergency room and into primary care and improving their health. To the opinion at the other end of the spectrum that Medicaid is basically worthless or worse than no coverage at all. This sort of channels the view that provider reimbursement rates are so low it's impossible to even get in to see a provider even if you have Medicaid. And as an academic interested in healthcare in general and healthcare that affects the poor in particular, I had followed this debate. I tried to do some research on it. It never occurred to me that the type of rigorous randomized evaluation that goes on all the time in drug trials and other medical trials could be applied to healthcare policy until a very fortuitous event happened in 2008, which was the Oregon Health Insurance Experiment. This came about in Oregon in 2008 because the state had money to expand Medicaid to some individuals, but not others. So this was, and this is one thing, a theme will emerge with randomized controlled trials. Some of the other examples that I give you is that often they come about precisely because a partner like a state or a local government doesn't have enough resources to cover the entire population they want to. And in this case, with no input from researchers, the state of Oregon decided that the fairest way, and this is often how randomized trials get started, the fairest way to allocate limited resources was not to do first come, first serve, because they were concerned that the people who would sign up for Medicaid first might be the most together and perhaps the least in need among a very needy population in general. They decided as a policy matter and consulting their stakeholders in the state that the fairest thing to do was to run a lottery. And that is what they did. In January and February of 2008, they ran a big public relations campaign and public information campaign in the state, getting the word out on buses and community healthcare centers, on the radio and homeless shelters, saying, we're going to expand Medicaid. There are limited slots. If you're interested, put your name on a reservation list. And afterwards, the state, the Department of Health and Human Services in Oregon, randomly selected names for about 8 months, starting in March 2008. And if the people who were selected, they were mailed an application and invited to apply for Medicaid. Now, for the state, this was the fairest way to allocate limited resources. For the healthcare policy community, it was an invaluable opportunity to harness the power of randomized evaluations to study what's arguably one of the most important public policy questions of our day, which is what is the impact of Medicaid? And so together with a team of academics around the country, state policymakers in the state of Oregon, and healthcare providers in the state of Oregon, we formed a research team to follow the people who had signed up, both those who won the lottery and those who lost the lottery, those who got on Medicaid and those who didn't, to see how Medicaid affected their lives. We're an energetic bunch presented with an opportunity. We want to make the most of it. So in this case, we really left no data stone unturned. We harnessed administrative data, hospital discharge records, emergency room visits. We sent mail surveys to people asking about things that you can't really see in administrative data, such as their self-reported health and well-being, how financially strained they were feeling. And then, just because we were really gluttons for punishment, we also conducted 12,000 in-person interviews and physical health exams to get detailed physical health measures of their blood sugar, their cholesterol, their detailed medications, etc. And we got and continue to get from this a wealth of information about how Medicaid affects people's lives. So just to give you a very brief overview of our findings to date, and there's much more on our website, which we have a snapshot of here, we found, looking 1 to 2 years after people had gotten on Medicaid through the lottery, that Medicaid increases healthcare use across the board. So people use the hospital more, the emergency room more, primary care, prescription drugs, preventive care like mammograms and cholesterol screenings. Medicaid reduced out-of-pocket costs and financial strain. It virtually eliminated the risk of having catastrophic out-of-pocket spending of more than 30% of your income. We found no detectable effects on earnings or employment. And on health, we found improved self-reported health, reduced depression, a 30% reduction in the probability that people report being depressed or screening positive for depression, no detectable effects on measured physical health like blood pressure or cholesterol. There was, I have to say, an enormous media response to this. I had never imagined that the kind of academic work I do could gain such attention in the media and the policy world. And I think this really is a testament to the power and importance of rigorous randomized trials, because while people, as you can see from this collection of headlines, interpreted the results very differently, depending on whether they chose to focus on the increased access to care and the improvements in depression and self-reported health, they said, Medicaid increases access to care, health insurance is an antidepressant. On the other hand, some people focused on the results that showed that emergency room use goes up, which was a surprise to some people, and that physical health didn't improve, and drew other conclusions that maybe Medicaid wasn't as worthwhile. So as you can see, there was an active debate, and this is just the media. A similar debate continues in the policy community about what our results mean. But to me, what is incredibly important, and why this inspired me to start JPAL North America and the Healthcare Delivery Initiative, is unlike any other study that I think any of my academic colleagues have done, no one was arguing about whether the results were actually results. It was clear what we found. That's the beauty of a randomized trial. As Quentin explained, you flip a coin. Some people are randomized to treatment, some to control. They're by construction the same on average, except for whatever treatment you give them. So any differences you find are due to that treatment. The differences between lottery winners and lottery losers were clearly due to Medicaid. And so what we're talking about is what these results mean, not whether we believe the results, which is really the power of a randomized controlled trial. And I have to say, you know, another thing people ask is, well, what did you learn if everyone's just drawing different conclusions and arguing different things, pointing to different results? Well, go back to some of the debates we put up in the beginning. So one of the claims you saw earlier on is this claim that Medicaid is worthless or worse than no insurance. And that we fundamentally reject with these results. It's just not true. The view that you can't get in to see a doctor at all relative to being uninsured is just not true. We've seen that Medicaid increases healthcare utilization, primary care, preventive care, et cetera. It increases people's reported access to and quality of care. It reduces financial strain, and it improves self-reported health. So the very pessimistic view that Medicaid was worthless is just fundamentally rejected by this study. On the other hand, some of the extremely optimistic views are also rejected. The idea that, you know, this is a win-win where covering the uninsured will get them out of the emergency room and save money so we can do well and good at the same time also turns out not to be true, at least in the short run. We found that Medicaid increased emergency room use overall by 40% and across all types of patients and visits. And because it's increasing healthcare use, it's not saving money. So again, this didn't definitively answer questions of, you know, what we should or shouldn't do with our healthcare policy, but it provides a narrowing of the set of arguments one can make for and against different policies. So that's what inspired me to start JPAL North America and encourage more randomized controlled trials. I want to give one case study of a randomized controlled trial we have underway. No spoiler alert here because we don't have results yet, but we're doing this in real time, and so as you'll see, we'll have results very soon. And this is a partnership that I'm doing with Dr. Jeff Brenner of the Camden Healthcare Coalition on something called healthcare hotspotting. And the question that he and many of us are interested in is how can we help the most expensive, complex need patients who are both in very poor health and very dire need, and also from a state and local budgetary perspective, extremely high cost. So the top 5% of patients in the U.S. account for more than half of healthcare costs. And the question is there a way that we can serve these patients better and perhaps at the same time reduce the fiscal pressures on patients, on hospitals, on employers, and on state budgets? So Dr. Jeff Brenner founded the Camden Coalition of Healthcare Providers, and he has an incredibly innovative program called Link to Care, which serves what he calls the super utilizers of the healthcare system. These are people who have been to the hospital more than twice over the last 6 months, have more than 5 chronic conditions, and are taking more than 5 prescription drugs currently. So these are extremely poor health patients. And his idea, which I think is extremely innovative and inspiring, is that when you see someone Camden is also a very low-income community, so you see someone in very poor health in a poor community cycling repeatedly into the hospital, obviously there are health problems, but something else was broken down in the social, emotional, economic fabric of this person's life. And so he has a dedicated team of nurse practitioners, social workers, healthcare coaches who go in and meet the patient in the hospital and ask them if they would like a variety of services that are designed to try and break this pernicious cycle of repeatedly cycling into the hospital. So the team tries to visit them post-discharge, and actually when we first met Dr. Brenner, we went and followed the team for a few days, and I think one of the people in the webinar today, Jason Turi, who's now working in New York, was actually the person who took me around and showed me how the program works and why it may be having an effect. They meet people right when they come back from the hospital. They try and get their medications sorted out. These people have massive quantities of medications, many of which are outdated or no longer supposed to be used. They try to get them in to see their primary care provider in the first 7 days post-discharge, to get them hooked up with the social services that they were previously eligible for but may not have signed up for. And the idea is that within 90 days, you've sort of gotten their life back on a stable path so that you can hopefully not only improve their health and their well-being, but break this pernicious cycle of readmission. This program has, for good reason, drawn enormous attention and interest from the media. Atul Gawande wrote about it in the New Yorker several years ago, for healthcare practitioners around the country who are trying to emulate it. And the initial indications are that the program is extremely effective. But Dr. Brenner is a real visionary, and he said, I think what we're doing is effective, but I really want rigorous evidence about whether it's effective and why, because if not, we're going to try something else. And if it is, we want to tinker with it to see if we can make it more effective. And so to see this, the way we often think about it is the goal of this program, if you had to boil it down to one thing, is to try to help these people stop getting constantly readmitted to the hospital, to stabilize them financially, emotionally, and physically so that they're not constantly cycling in and out of the hospital. So imagine someone who goes to the hospital in 2014. They've had a whole bunch of hospital readmissions over the past year, maybe an increasing rate of readmission as things have gotten more and more out of control for them. And what the studies to date have done is then followed them after, the Link to Care team intervened to see, can we get the readmission rate down? And you see in this picture, it looks like the readmission rate is going down. So maybe this program is having a big effect. But what we don't know is what would have happened to these patients if they hadn't had this intervention. And it's hard to just, compare to other people because the other people are different, the people who are not getting the intervention. The brilliance of a randomized controlled trial is whether or not you get the intervention is decided by the flip of a coin, and therefore you can compare to what's called the control group who didn't get the intervention but was eligible for it to see what would have happened. And again, going back to the very important issue of ethics here, why did Dr. Brenner do this study? Not just because he wanted to know the answer, but because he, like many people trying to do good work in the community, is financially constrained. So they were already only serving about 50% of patients who showed up in the hospital who met all those eligibility criteria I described, except they were kind of doing it in an ad hoc manner. Today we have someone available, tomorrow we don't. Some patients got help, some didn't. Instead, with our help, we designed a randomization so that certain patients are going to be randomized into the study and certain not. And so rather than doing it in a somewhat ad hoc manner, we do it in a completely ad hoc manner, otherwise known as a randomized evaluation. And then we can follow the control group. Now, these are all just pictures because, as I said, the study is ongoing. But we can see what is the counterfactual, this line in blue. What happens to the people who are randomly not included in the study? Do they actually, kind of have their healthcare use tail off shortly after the intervention, which you might think. Maybe some person's gotten really a bunch of bad events. And so just by chance, if you kind of did nothing, their healthcare use would tail off. And then you compare the blue and the red line in 2015 and you think, maybe this program didn't have much impact at all. Or maybe, in fact, when we look at the control group, we see that after the intervention, their life went from bad to worse. And far from declining readmissions, the readmissions spiraled out of control. And then we'd estimate a much bigger impact of the program. But to know this, we need that randomly allocated control group. So what we do, and as Quentin mentioned, one of the things we look for in partners is some data infrastructure. Dr. Brenner's team is really at the forefront of data systems, and more than one needs to participate in our process. But it's a joy to work with. They have a health information exchange set up in Camden, New Jersey, which provides daily reports of patients from 2 hospitals who have come in with more than 2 admissions in the previous 6 months. Staff review the hospital chart data to verify other eligibility criteria, and then they flag a patient has just been admitted to the hospital who meets these eligibility criteria, at which point we send a Camden Coalition staff member, often a nurse or a social worker, to meet the patient in the hospital, to explain about the program that they may have an opportunity to participate in, to explain that we don't have enough resources to cover everyone, but if they're interested in participating, we can see if we can get them eligibility for the program. If they're interested, which the vast majority of them are, we obtain consent. And then in real time, we randomize using a survey software on tablets. There's a conversation carefully scripted with the help of, as I said, Jason, who's on this phone call, to make this a conversation that's respectful to the patient and beneficial to him regardless of the outcome. They also get a gift certificate either way, so that they get some benefit. And then, and this is the part where, unlike in the Oregon experiment, we're trying to make things much cheaper and much easier. Rather than do costly surveys and in-person exams, we're harnessing the power of rich administrative data to not only follow these individuals at low cost to us and to our partner, but also to get real-time analysis of our key outcome, which is hospital readmissions, because this health insurance information exchange, the health information exchange that the Camden Coalition already had set up, not only tells you when someone has come in who's eligible for the program, but when they come back. So we can see both in the treatment and the control group what readmission rates are like. And this is a 3-year study simply because of the time it takes to recruit enough patients. But we're looking at 6-month readmissions, and we can observe 6-month readmission rates 6 months later. So this can really provide real-time results, and we'll have the study completed in about another year, and we're extremely excited to see the results. So I talked about that one in a fair amount of detail. I could go on and on about many studies that I and the affiliates of JPAL are doing. I just wanted to mention a few more just to give you a sense of the range of different things, right? So on the one hand, you have the Oregon Health Insurance Experiment, which is on a major policy issue concerning Medicaid, and it's a statewide person-level randomization. We talked about the Camden Healthcare Coalition, which is a nonprofit that we're working with, also randomizing at the patient level. I want to give you a flavor of something very different, which is a partnership we've undertaken with the federal government, the Center for Medicare and Medicaid Services, as well as the Social and Behavioral Sciences team at the White House, which is to deal with a problem that they came to us with, right, to say that can you help us with, which is they're concerned about overprescribing in Medicare Part B. They're particularly concerned, as I'm sure many of you know, about issues of Schedule II controlled substances or opioid abuse, and they already had a process in place in which they send letters to physicians suspected of overprescribing high-risk controlled substances. So they send a letter saying it looks like you're prescribing way more Schedule II substances than anyone else in your state and your specialty. We are concerned. They've been doing these types of letters in Medicare Part D for a while. They do similar letters for billing for physician services in Medicare Part B, and they had a great question, which is, are these letters having an effect? Is there a way we could design these letters to have more of an effect? And we don't have the time to wait 10 years to see your seminal study on the long-run effects of these, and we don't have the money or the resources, staff or otherwise, to start doing surveys or anything like that. We need a quick answer at low cost. And so the study we worked with them to design is just like, hey, this month, instead of sending all those letters, let's randomly pick half of the physicians to send letters to. If you're interested in whether what they told us they were interested in is in 3 months, can we reduce their overprescribing behavior? Once again, real-time administrative data, this time from the Medicare claims database. 3-month outcome, 4 months later, we can tell them the results. This paper is already published, and so the results are out there. You can find it on our website. These letters were having no effect. That's what they discovered. But now we're working with other members of our team, and we're harnessing insights from behavioral sciences, psychology, et cetera, to try and design the letters to be more effective, because we know a lot about what types of letters tend to get people's attention and be effective. We're also trying some fairly more prosaic, but I think really important things, like making sure they have a current address for the physician, right? And so these are the types of things that our researchers and our staff want to work with partners for to improve the effectiveness of their intervention and knowing what works. Another example also where we're randomizing at the physician level is in the area of clinical decision support. Clinical decision support is designed to notify physicians in real time when something they're doing is considered not recommended. In this case, we're looking at clinical decision support for radiology orders. So there's a big concern in the country about too many scans or over-scanning MRIs and CTs that aren't needed, that cost a lot of money, and that may actually do harm to the patient. The American College of Radiology has designed professional guidelines where, based on the patient's clinical information, as you can see on the screen, they pop up and say, red means, this scan is not advised, green means, the scan is great, and yellow is we're not sure. The Center for Medicare and Medicaid Services is about to start requiring that they won't reimburse for scans unless people are using a clinical decision support system. And yet, we know very little about the impact of these support systems. There are promising observational studies which show that when a hospital introduces one of these systems, you get a decline in these non-advised scans. But most organizations, when they implement something, they do many things at once. They do a big campaign, they talk to their providers, etc. What Medicare is thinking about is just scaling this up across the country. We're working with one hospital already and bringing a couple more on board, and they've randomly assigned at the physician level whether you get this pop-up screen when you go to order a scan telling you whether your scan is advised or not, and that's going to allow us to see what the impact is on scanning behavior and also on all kinds of other outcomes about what the physician chooses to do instead and how that affects the patient. So those are just two examples. There are many more. You can go to our website and see examples of current studies underway. The main thing I want to emphasize is that almost everything of the types of problems that you may be thinking about in your own work and life are potentially studyable with a randomized evaluation, and it's our job to help you figure out if that's possible in your case. So just to free associate for a moment on types of ideas, some of which, variants of which are underway by our affiliates, how to improve preventive care, getting people to get their immunizations, their flu vaccines, or their recommended screenings. One could think about randomized interventions to the patients, reminding them to come in, asking them to set a plan and a deadline, which some psychology work has shown helps people carry through on their intended action, because many people say, I plan to get a flu vaccine, and then they just forget. Also, interventions on the provider side, saying, oh, you have a patient in your office, let's have a best practice alert pop up and remind you that you should be encouraging them to do some screenings. How do we do that in a way that's effective and useful to the provider and to the patient? One can imagine all kinds of designs randomly assigned to patient and or physician to get at that. Another set of issues include improving the environment for care providers. One thing we've heard about, some of the issues that people have come to us with, is how to reduce postpartum length of stay among mothers. It's very costly to be in a hospital. A new mother presumably wants a lot of support. Can we provide that in the home in a way that is perhaps better for her and less costly to the hospital and the taxpayer? Again, going back to the concern about opioid abuse, there's an interest in whether having a pain specialist or a consultant in the hospital can help get a patient on the right track and not addicted to opioids. Physicians have a lot of interest in telemedicine, virtual visits, as a way of making it easier on a patient to get the physician care they need without the commuting time and to be able to see more patients. A whole other set of questions basically concern resource optimization and operations resource issues. For example, one thing I learned talking to Dr. Brenner in Camden is a lot of what they do to help their post-discharge patients is get them in to see their primary care provider. Often the primary care provider is full, and so people get on the phone and try and get their patient in to see the provider. And I said, well, that's nice for that patient, but presumably it's bumping another patient. And Dr. Brenner said to me, oh no, in fact, it's a paradox. On the one hand, no one can get an appointment. On the other hand, the physicians are sitting there with a ton of no-show rates. And so one thing we've been talking with him and others about is there a way to use the kind of software that restaurants and airplanes use all the time to predict how many people or whether someone's going to show up for an appointment, and to try to, if you have one slot and you think the no-show rate is 50%, maybe we should schedule 2 people on that slot and actually just use the physician and the patient's time better. Similar issues with staffing of the emergency department. Again, there's a problem that, when there's an emergency, you need a lot of people there, but when there's not, how can we more effectively use the staff's time? Should we be providing some kind of outpatient clinic services, et cetera? And again, these issues related to outlier billing or suspected waste, fraud, and abuse. What's the most effective and least confrontational way to try and reduce this kind of outlier billing of providers? Moving from the provider environment to the insurance environment, a subject near and dear to my own heart, there's a lot of innovative ideas in the insurance space about how to make insurance more valuable to the patient at lower cost to the patient as well. Questions about using reference pricing to set, reimbursement for certain types of services, using value-based pricing design to encourage the use of preventive health care and other things considered of high value. What the impact is of providing limited network plans for both patient health and well-being, and also provider costs. And finally, drawing out as big as possible to system-wide innovation. We have affiliates doing randomized controlled trials trying to implement better hospital management practices to improve the overall quality of the hospital. There's a huge amount of interest also in the policy world about accountable care organizations and bundled payments or shared savings contracts. What do those actually do to patient care, both cost and health, is something one can study. Again, that's an example where often when you implement one of these contracts, you don't put all patients under them at once. You start with one employer or one group of patients. One could imagine randomizing which patients are initially under the bundled payment scheme and which are not. So as I said, this list is by no means meant to be exhaustive or definitive. It's hopefully to give you some sense of the wide array of different problems confronting different actors at all kinds of levels, the patient, the provider, the hospital system, the healthcare system, that are amenable to rigorous evaluation through randomized controlled trials. And as I said, myself and many of our affiliates are extremely eager to partner with people who want to understand the effect of what they're doing or considering doing, or they're thinking of 3 versions of it, which would be most effective and why, and to help improve the efficiency of the use of our healthcare resources to deliver the best care possible for a needy population. So I'm going to turn it back over to Quentin now to just wrap up, and we'll look forward to hearing your questions.
Thanks so much, Amy. So before we turn over to questions, I just wanted to walk through the next steps on the innovation competition. So as I mentioned before, our deadline for the submission of letters of interest is June 17th. And as I said, these letters can be quite short. They can be 3 to 5 pages. And we're happy to work with you to design the scope of what you're going to put in those letters. We will have another webinar for potential partners on May 19th, and that will be led by Kate Becker, who's an affiliate professor, a JPAL affiliate at Harvard, and she's leading a terrific impact evaluation relating to the nurse-family partnership in South Carolina. Very interesting work there, and also led by Jason Bauman, who's our initiative manager. So that'll be a really interesting webinar, and there'll be other opportunities to engage there. We'll accept the letters of interest as soon as you're ready to submit them, and until June 17th. And then we will announce the winners on sometime before July 15th of 2016. So please reach out to us, and we're happy to discuss this in more detail. But now I'm going to open the floor for questions, and we can talk through anything you have on your mind. We have a couple questions coming in, but as I said before, there are 2 good ways to pose questions. One is through the dialog box on the side of your screen, and the other is through Twitter at JPAL_NA. So I'm going to take the first question. First question that we have here is whether there are particular topics within healthcare delivery that we're particularly interested in addressing. And I think that the answer to that is that we view this as what's called a pull mechanism, which is to say that we're quite interested in a fairly wide range of programs and innovations. We want these to be policy relevant. And you know, we obviously have an interest in the overall sort of social welfare aspect of this, but we're actually quite interested in having you come forward with ideas that are on your mind. So our definition of healthcare delivery for these purposes is really quite broad. I'm going to take a second question here, and maybe Amy, you can take this one. This is sort of what are the kinds of programs that are the best fit for the competition?
That's a great question. I mean, the first answer I think sort of echoes Quentin's, which is there are many things that are a great fit, and one of the reasons I went through a bunch of examples was to try to make clear that one can do both large-scale statewide policies, one can do smaller-scale targeted policies, and either way, they're of interest to us. I want to also emphasize what Quentin said, is that it's most important that it's a question that the partner wants to know the answer to. And beyond that, I think, you know, then there are technical requirements. You need to be able to measure the outcome you're interested in some type of data, ideally administrative data, to make it relatively inexpensive to do. So if the goal of the program is to improve patient sense of empowerment, that's a very useful and laudable goal. It's a little hard to measure easily in administrative data. Similarly, there needs to be a reasonable scale so that we actually have the sample size to be able to detect things, or you need to have the patients to let us, as in the case of Camden, run it for a year or two. But I think we've less had the problem of people coming up with proposing things that were not amenable to studying through an RCT, and more the problem that people don't assume that their problem can't be studied rigorously. And so we encourage you to give us your suggestions and work with us to see how it's most feasible to work.
Great, thank you, Amy. So we have a few more coming in. So one question is, how many programs are we looking to fund? And in the short term, I think that the answer is probably somewhere between 2 and 4 in this round, and there may be opportunities down the road as well. We, as I said, we funded 14 interventions so far. And we sort of are continuing to grow that work, but I think in terms of this round, it'll probably be somewhere between 2 and 4. There's a question, is this competition open to nonprofits only and to government agencies? And the answer is no. We sort of subject to the other sort of considerations that we're talking about, in terms of the policy relevance of the question and the impact on populations that we are particularly concerned about. I think that we're open to a variety of different partners. There's a question about public health intervention. Would you like to?
Sure. There's a question that says, thoughts on public health intervention. My thoughts are that public health intervention is very important, but I assume the question is about whether that's in the scope of our initiative, and the answer is absolutely. That's why I gave the example of flu vaccines. One could imagine, given some of the current concerns about the safety of drinking water in poor communities, designing interventions there as well. I think we take a view of the healthcare system touches on lives in many ways, and we're interested in finding effective solutions through any of those portals, including healthcare delivery. There was also a question about would there be assistance for the design of the random component itself. Absolutely. I mean, in some sense, I feel as an academic, that's where we have the most to offer a partner. The partners who are running these programs, again, I'm just drawing on some of my experiences with the Camden Healthcare Coalition and other similar partners. They know their population and their intervention better than we do. It's our opportunity and privilege to learn from them about the work they're doing. Where we can hopefully provide value is exactly in the design of the randomized component, the literal implementation of it. I showed you in this example through tablets, etc., and working with the partner, as we did in this case in Camden, to make sure that that integrates seamlessly into their actual program delivery and mission in a way that's not disruptive to what they're doing. That and the the actual analysis of the data down the road is where we add the most value. What we need from you is a question you want answered, a willingness to engage in rigorous randomized evaluation, and some ability to help us put our hands on the data we need to answer the question.
Yeah, and I would also sort of, in explaining the sort of structure of JPAL North America, we have both this affiliate network of 131 affiliated professors across the country who are really very experienced in this, and this full-time staff at MIT of sort of research and policy folks. And with respect to the sort of full-time staff, we're happy to work with you. And one of the designs of this program actually is to try to work with you in a relatively intensive way to try to help you define the survey, the randomized component, all of the pieces of it that we'll need to do, and to do some matchmaking with scholars who can help as well. So we certainly have a pretty broad conception of what we're willing to kind of help you work out, as long as the question is one that we want to work on.
Just to piggyback on one other thing, I would say that you guys also are, in some sense, working with us. You benefit your similar types of organizations throughout the country. So just when we work out how to do something in one setting, we can often apply it to another. So a lot of what we can do is harness the lessons from the trials we've already done to make your life easier. An example of that is with the Camden Healthcare Coalition. We, sort of worked out the bugs of how do you, as I said, sort of engage in this respectful conversation about willingness to participate in a randomized controlled trial with a patient who is in need. And obviously this is something that the medical community does all the time, and so we had a lot to work with, but still it needed to be worked out how to do the real-time randomization once the patient consents. And now with the Nurse-Family Partnership, which is another randomized controlled trial some other affiliates have underway, they've been able to learn from those lessons and just port over a relatively seamless process. So, we have a lot to offer, not just the expertise of our staff and our research affiliates, but also all of the experience we've had working with many of you to date makes all the subsequent projects we're now doing all the more easy and efficient.
Great. So the next question is, are nonprofits with community-based interventions eligible to apply, and if yes, do they need to have an academic or research partner already identified, or will JPAL help with the finding of a research partner? So the answer to that is that yes, nonprofits with community-based interventions are absolutely eligible to apply. And no, you don't need to have an academic or research partner already identified. Part of the process that we're envisioning in this program is actually to help with the matchmaking for the research partner. That's in the sort of phase one of this that we're talking about here. When you get to the phase where you would apply for larger funding to actually do the evaluation, at that phase we would have a JPAL affiliate as part of the project, and that would be something that you would apply jointly. But that's not this program. So I'm going to go to the next question. Can private service providers, the non-governmental agencies, submit a letter of interest, or does the letter of interest need to come from a government partner? So the answer to that is that we are accepting letters of interest from across the healthcare space, and so it doesn't need to come from a government agency. We'll look at it on the basis of the sort of policy relevance and the importance of the question, and whether it's the kind of thing that we think that we can do, and so we're happy to receive those letters broadly. So moving on to another question. What capacities and bandwidth must the submission team have to execute the evaluation? Maybe you should take that.
That's a great question. Part of the reason we're providing some financial support and a lot of staff support is to try to minimize the capacity and bandwidth needs on the implementing partner's end. A lot of what we consider it our job to do is to help with the types of things like how do we actually do the randomization once we get the data, how do we find the study participants in that data, and to do all the analysis. So our aim is to make this as easy as possible for the implementing partner, but it would be disingenuous and counterproductive to say that it would have no impact on the implementing partner. They will need to have some conversations with our staff and with our research affiliate in order to make sure that they can do it. And often the actual randomization component, the design of the randomization component involves talking to some IT people. Often the data pull itself involves talking to some people in the data or IT space. So we try to keep it as limited as possible. If you have no more than 30 minutes of your time to give as an organization, it's not going to work. Beyond that, how much it does depends on the type of the project. The example I gave with the letters to prescribers from the Center for Medicare and Medicaid Services, they were already sending the letters. So that work was almost entirely with the IT staff to make sure that they were randomly sent to some, and with the data team to make sure that we could link to, we could have the data we needed so that we could look at the outcomes. None of the people actually writing the letters or involved in talking to physicians who get a letter and call in were affected by it. In other cases like the Camden Healthcare Coalition, where it's affecting the recruiter's daily script when they're trying to get people to participate in the program, they have to be trained in a new script, and we needed to work with our partners in Camden to design that. That wasn't something as academics we felt comfortable designing on our own, so that involved more effort from the partner. Most of the effort, I would say, is front-loaded in the sense of once it's up and running, it kind of runs itself, and as I said, we can deliver all the analysis, and usually we like to do projects in which you can get the analysis in close to real time because we know that people want answers. So I think we'd be happy to talk in any specific case because I realize it's an important question in thinking about this, about how much involvement it would be. As I said, we try to keep it as limited as possible and to be as helpful as we can, but it is not zero.
Yeah, and the other thing is we're hoping to help you answer questions that are relevant to you. So some of the work that would go into it is work that helps you to design your program in a way that maximizes its effectiveness and allows you to expend your resources in an efficient way. So there's a question, will a copy of this webinar be made available to attendees or online so we can share with colleagues that were unable to attend? The answer is yes. So we're recording this. We'll put this on our blog and our website, and we will also put it out on YouTube. And we also would love to hear from you about colleagues that you think that we should be in contact with. So we'd love to have follow-up conversations with anybody on the webinar, but we're actively looking for partners here. And if there are people you want to connect us with, we would be happy not only to share the webinar with them, invite them to the next one, but also have a conversation with them. The next question, which would be for you, Amy, what if we are researchers ourselves, how do we initiate a collaboration with a JPAL researcher?
That's a good question. I think, the primary purpose of this, I mean, we run several different types of initiatives at JPAL. This particular one, as Quentin described, is primarily targeted at implementing partners, so people who have programs that they're doing. Some of those people may currently be working with a researcher, and so, obviously, that's useful as a starting point. If you're a researcher not connected with an implementing partner, this particular initiative is not specifically targeted to you, but naturally, if you have an exciting idea for a randomized controlled trial that you think is feasible, the staff is always delighted to talk with you and hear about it, so I would urge you to contact them.
Yeah, I would say also that sort of at the next phase in this process, so at the phase in the process where we have the where we actually fund the research design, those applications always have to have a JPAL affiliate attached in some way, and so there are ways to partner, but those resources are primarily available for JPAL affiliates and the projects that they're working on with implementing partners. Sorry, one second. Oh, okay, there are a couple more questions. Will there be other rounds of the competition in the future for those who missed the June deadline? We don't have a particular next round of this particular competition planned, but this is an initiative. The Healthcare Delivery Initiative is one in which we're very invested, and so my hope is that there will be continuing opportunities to work with you if you missed the June round, and we'll see how it goes with this one. The next question is an IRB process required?
That is another, this is Amy again, that is another excellent question. Certainly, as an academic and any academic affiliate, we need to get our institutional review board at our home institution to consent and to approve the project. Whether the implementing partner needs IRB approval very much depends on their specific situation. We've had everything from, the institution, the partner institution having its own IRB that requires full approval of the academic one ultimately ceded to them, to the implementing partner basically having the view of we're doing something for operations, for which we don't need IRB approval, the academic can get IRB approval on their end. We have several staff who know an enormous amount about all these different types of very important issues regarding both institutional review board and as or more importantly, just the ethical treatment of human subjects. It's something we take very seriously. It fits into the category of something that we try to mostly handle on our end. Certainly if the implementing partner has no requirements from it on their end, we will handle it entirely on our end.
So that's the last of the questions that came through our chat box and through Twitter. And we're at the end of the hour, so that works out perfectly. We do encourage you to reach out to us if you want to talk further about how to submit a letter of interest. And as I said, the letters of interest are due on June 17th. Thank you so much for joining us today, and we hope to have a chance to work with you again in the future. Thanks a lot.
Thanks very much.